bit, we're going to continue with another ventricular tumor, a subependymoma. The first case is a 44-year-old male patient presenting with headaches, and on imaging you can see an intraventricular mass in the right frontal horn with cystic degeneration and little or no enhancement. The tumor is not encapsulated, but it's a very firm tumor, and from a radiological point of view, the differential diagnosis would be a subependymoma, as in this case, or a central neurocytoma that we discussed in the previous video. And central neurocytomas occur in patients between 20 and 40 years, but they enhance more vividly, and they have a close relationship to the septum. Subependymomas occur also in the fourth ventricle. In fact, the majority of subependymomas occur in the fourth ventricle, and they occur in the fifth and sixth decade, so a little bit older than the patient we started with. And when you look at the location in the fourth ventricle, it is always below the body of the fourth ventricle and above the apex, so above the opening of the central canal. And it is thought that this location of a subependymoma coincides with the location of the area postrema, so one of the circumventricular organs. And we talked about the circumventricular organs in a video a long time ago on neuromyelitis optica. And subependymomas have upregulation and redistribution of aquaporines, and also in the supratentorial region they are thought to arise from the circumventricular organs and from stem cells. And in infratentorial subependymomas, there's upregulation of aquaporines in the entire tumor. You can see the aquaporine 4 in brown and the aquaporine 1 in brown infratentorial on these images. And in the supratentorial subependymoma, it's located along the borders. And subependymomas are a tumor that we've known for a very long time, way before imaging. So in the 1940s, just after World War II, there was a case report of, there was a series of 7 cases where they described tumors arising from the subependymal glia, postulated to be derived from residual periventricular matrix. And this case presented in the late 1930s, and there was no imaging back then, so they did a posterior fossa exploration. The patient presented with nausea, vomiting, vertigo, headaches, and tinnitus, and the symptoms of the subependymoma are caused by the hydrocephalus and the increased intracranial pressure. And this patient died from a pulmonary cause in the 1940s, so they had the macroscopy of this tumor. And you might remember that the central neurocytoma arises from neuronal progenitors in the septal region. And when you look at the lateral ventricle, the subependymoma arises from the radial glial cells in this yellow region that is going to give rise to the neocortex. And if you look in the adult situation to the way the ependymal lining is built, you have the ventricles with the CSF in it, then you have this layer of ependymal cells, and then just below this layer of ependymal cells there's a hypocellular gap with processes from ependymal cells near the ventricle and a ribbon of astrocytes with processes into this hypocellular layer. And then below that there's a transitional zone into the brain parenchyma. And subependymomas arise from this subependymal plate. There is a larger case series with histopathology from the Armed Forces Institute of Pathology. You can see, for example, a patient presenting with bilateral subependymomas with kystic degeneration, which occurs only in the supratentorial subependymomas. And this is the histology of a supratentorial subependymoma magnified 100 times. And this is an infratentorial subependymoma, and you can say that this is a more firm tumor. And there are sometimes mixed histological patterns. And if there is a mixed histological pattern, the most common one is that of an ependymoma with a subependymoma. And when you want to predict the risk for the patient, the molecular pattern and genetic profile is more predictive than the histopathological grading. And you might know that in the most recent WHO classification, the ependymomas and the ependymal tumors have been rearranged. So there are 3 locations, and at each location 3 different molecular profiles with different risk profiles. And subependymomas arise from periventricular radial glial cells or neural stem cells, and usually tumors arising from progenitor cells are very aggressive. And subependymomas are only grade 1, and that's probably because they have a balanced genome. And it might not come as a surprise that after this subependymoma, we're going to look at the other ependymal tumors and continue with the ependymoma in the next video.